So thank you all for joining us for Advancing Care and Non-Clear Cell RCC, Optimizing ICI and TKIs. Today is the second session in our webinar series, and it's on key clinical trial data. I will turn it over in just a second to Dr. Powell. He will give a presentation, and then we'll have a case discussion. If you have a case that you would like to ask about, we're certainly encouraging you to do so at that point in time. And then there's opportunity for questions and answers, and then we'll wrap up. I will also, at the end of today's session, I will send out an email with a link to what we call a rapid recap, which just kind of takes everything and summarizes it nicely, as well as a link to the evaluation to make sure that you're able to evaluate the session and claim your credit. So thank you again for joining. And Dr. Powell, I will go ahead and turn it over to you now.
Oh, thanks so much, Ashley. I really appreciate it. It's a very interesting series that we put together. I've been working very closely with Pedro Barata, who's a terrific investigator at Case Western University, to put this together. And it's a four-parter, as Ashley had mentioned. We can jump to the next slide here. Session 2 is titled Key Clinical Trial Data, and we're going to be focusing on current emerging therapeutic approaches. Session 1 focused on the biology of non-clear cell kidney cancer, and Session 3 will kind of build on some of the themes here. And in Session 4, which is, I think, also a very important session, we sort of tie together toxicity. Next slide, please. I'd mentioned Pedro, who's the Migo Family Chair in Cancer Research at Case Western. He's been a tremendous help in putting these slide decks together. I'm a medical oncologist based at City of Hope in Los Angeles. I've been there for, gosh, almost 20 years now. I'm going on my 19th year there. And I'm a professor and vice chair of academic affairs. And my practice is almost entirely kidney cancer these days. Next paragraph. Next slide, please. Important to note our disclosures, which are all cited here. Let's go to the next slide. And of course, this program has several accreditations and credit designations, including the ACCME and ANCC. So if you need a scan for the syllabus for this, please go ahead and do so. Next slide, please. So we have two general objectives today. One is to really improve your ability to contrast the clinical data and current use of checkpoint inhibitors, tyrosine kinase inhibitors, and combinations thereof. And we also want to help improve your knowledge and skills in understanding the clinical profiles of these therapeutic domains, specifically for non-clear cell kidney cancer. Next slide, please. So we have a couple of introductions, and then we'll go through the immune checkpoint inhibitor therapies that are available for non-clear cell disease, and we'll dive a little bit deeper into papillary, and then we'll go through some presentations and case discussions. Next slide. So we're going to start with a question here, which is, what do you know? Which phase 2 combinations for non-clear cell kidney cancer demonstrated the highest objective response rate with an ORR of 49%? Is it cabo-nivo, len-pembro, nivo-ipi, or cabo-nivo-ipi, the kitchen sink approach, if you will? So we'll take a look in just a moment what folks responded with. We can jump to the next slide here when folks are done with the survey. So most suggested len-pem, some suggested cabo-nivo. Very good. Let's go to the next slide. On a scale of 1 to 5, how would you rate your level of agreement with the following statement? I'm familiar with the clinical trials currently testing combinations of TKIs and checkpoint inhibitors for the treatment of non-clear cell kidney cancer. Would you strongly agree, disagree, strongly disagree? This is a place where, again, it's not something that one would see commonly unless you've got sort of this unique unicorn practice like mine where I'm seeing almost exclusively this disease. So it looks like we've got a varying scope of knowledge here on the call. Great. Okay, that's a good place to start. Let's go to the next slide here. So let's go through some non-clear cell kidney cancer clinical trials. This is a nice slide that really sort of highlights some of the work that was done in yesteryear for non-clear cell kidney cancer. And these are, what I would call lumping studies. So if you look at these very cleverly named studies, ASPEN and ESPN, named for skiers and sports aficionados, you can see that these trials compared sunitinib and everolimus, and this was a very reasonable comparison. There was some suggestion that some non-clear cell subtypes might be driven by mTOR biology, and in fact, that's true. But frankly, in both of these experiences, it looked as though VEGF TKIs, such as sunitinib, seemed to edge out everolimus. And these were not, wildly declarative studies. They didn't necessarily establish a quote-unquote standard of care, but nonetheless, they were important. There was also a phase 2 clinical trial reported much more recently that actually combined these approaches, looking at lenvatinib and everolimus. And this was a phase 2 single-arm study with actually a much healthier response rate of 26%. And I'll tell you, within that particular study is a subset of patients with chromophobe kidney cancer that seem to have a response rate of 44%. So chromophobe is one of these very difficult diseases to tackle. And I think that this combination of lenvatinib and everolimus is a very reasonable strategy in that context. There have also been studies looking at bevacizumab with everolimus, and this is sort of hinging on a number of phase 3 studies that we had in yesteryear. Some of you might remember studies like Interact, for instance, which looked at these combinations. There, the response rate was 29%, but again, even though that's a high response rate, it's not a combination that's made its way forward in clear cell kidney cancer, so it hasn't really made its way forward in non-clear cell kidney cancer either. Let's jump to the next slide here. So this is a summary now of all the studies in the combination domain, and we're going to be going through some of these in more detail, but you can see sort of a range of response rates. And I like this table. It offers a nice juxtaposition of all the studies that are available, but the devil is really in the details with these clinical trials. It's so important that we look at studies that are randomized versus non-randomized, studies that are retrospective versus prospective. You can see some retrospective studies that are sort of lumped in here, and those tend to have varying results. Let's go ahead and go through the next slide here so we can actually sort of see some of these trials in a little bit more detail. This is a very important study, Keynote 427, and it's actually a fairly healthily sized study with 165 patients. Now, it's non-randomized, so take that with a grain of salt. But if you look across the spectrum of patients here, across this very large cohort, which was published in the JCO, I remember this, I was one of the reviewers a couple years ago, you can see that the response rate is a very healthy 27%. So it really suggests that perhaps, I want to underscore that, there's some theoretical value in using a single agent checkpoint inhibitor in patients with non-clear cell kidney cancer. Now, again, the devil's in the details. So if you go to the individual subtypes, you can see papillary and chromophobe and unclassified. And there it becomes a little bit challenging to sort of suss out what's driving the benefit here. But it seems as though papillary and unclassified subtypes are really the ones that are garnering benefit. Now, what's a little bit different, despite the fact that, with checkpoint inhibitors for clear cell kidney cancer, we see a tail on the curve, right? We get responders that respond for eons. What you see on the right-hand side is that the median progression-free survival is only 4.5 months here. And that's a little bit daunting because you can see that within this cohort, you have this real drop off as time goes on, and there are very few people that actually get beyond 2 to 3 years within this cohort. Let's go to the next slide. Now, what about tyrosine kinase inhibitors and checkpoint inhibitors? This is data that was updated by Kelly Fitzgerald. She was at Memorial Sloan Kettering as a fellow. Now she's at UCSF. This was published in European Urology. In this study, you have progression-free survival associated with the combination of cabozantinib and nivolumab of 13 months. You have a median overall survival of 28 months. And when you look at individual patient outcomes, you can see that the preponderance of patients here had papillary renal cell carcinoma. I always like to sort of tease out the proportion of patients that were papillary and look at their response rate, and here it was around 47%. Next slide. If you look to the individual data sets here with progression-free survival, you can see a value of 12.5 months, median overall survival 28 months. So this data is distinct from what we see in the context of clear cell kidney cancer, where certainly the milestones are better. You typically see a median PFS of closer to 16 months with Cabo and Evo there, but nonetheless appreciable. And you can see the response rates overall, 48% are pretty healthy. Now, I will highlight the fact that there are patients that really don't tend to respond to this regimen, and those are the chromophobe patients. So I'll highlight again that there seems to be something special about lenvatinib, and we'll see that later. Next slide. This is the Keynote B61 clinical trial, which is a very important study, the largest of the studies that we have to date in non-clear cell kidney cancer. And it had 158 patients. And what you see here is that there's a response rate of, in this case, 49% overall. And you remember that from our questions at the outset. but a 12-month progression-free survival rate of 63%, which I think is quite impressive. And if you look at overall survival, that 12-month survival rate is 82%. You can see that many patients do have large and deep responses to therapy, many patients with papillary histology. So this is certainly a reasonable treatment option in this subset of patients. Next slide, please. Now, this trial of Cabo, Nivo, and Ipi is ongoing at this point in time. You can see a response rate in non-clear cell kidney cancer of 21%, with papillary specifically around 25%. I wouldn't say that this is necessarily a home run as far as trials go, but it is, in this case, again, an important academic effort because we did want to have some semblance of whether or not doubling down on therapy with both checkpoint inhibitors and immunotherapy would be a viable approach. Next slide, please. I wanted to spend a little bit of time going over this study. And for those of you that are listening, seeing patients in the clinics, this is a study that I could really use your help with. So at this point in time, we have a bunch of single-arm studies. You saw the data from Keynote B61 with lenvatinib and pembrolizumab. Important effort, but really not subject to randomization. This is a study looking at zanzalintinib, which is also known as XL092 in combination with nivolumab versus sunitinib. We always tell our fellows, and we always emphasize this when we're in the clinics with them, randomized data is really the high watermark. We can only lean on single arm clinical trials so much, and at some point we really do need randomization in order to really balance efforts and understand the true benefit of a therapeutic strategy. So this study is going to look at zanzalintinib, which is a novel VEGF TKI. It has theoretically some properties that are similar to cabozantinib. There's blockade of VEGF and MET and AXL, but there's some very unique pharmacokinetic and pharmacodynamic properties of this compound. The biodistribution of this agent seems to be different. And in my experience, I've had a fair amount of experience with this drug, and I've reported out some of the data at some of the KCA meetings more recently. What we see is that there seems to be a tolerability profile with this agent that's distinct, and also beyond that, an activity even in patients who have received prior cabozantinib, which I find to be very, very intriguing. Next slide, please. So we do need your help with those randomized efforts. Now, what about the single-arm studies of tyrosine kinase inhibitors? So as mentioned, this is a trial of lenvatinib and everolimus in combination, and I bring this up really to emphasize one particular cohort, and that's the cohort of patients with chromophobe kidney cancer. Overall, the response rate here is 26%, nothing that I can truly distinguish, but as opposed to other data sets where we really don't see our poor chromophobe patients really deriving much benefit, here with lenvatinib, they really seem to be deriving at least some signal of advantage with this response rate of 44%. I don't want to hang my hat on just 9 patients. Again, in keeping with what we try to be honest and realistic about with patients, this response rate of 44% probably wouldn't put this regimen on the map in most cases. But I do think it's nonetheless a respectable response rate. And for our patients with chromophobe who otherwise have very limited treatment options, I think it's a very reasonable strategy. Next slide, please. What about immune checkpoint inhibitors and anti-CTLA-4? Now, this is an approach that I think we all wanted to hear more about, this combination of nivolumab and ipilimumab. It's something that we use frequently in the frontline setting for clear cell renal cell carcinoma. I use it all the time, sometimes with really phenomenal outcomes. So this was a one-to-one randomization to Nivo-Ipi versus standard of care, and this was designated by the investigator. It's not an unreasonable way to think of conceiving of a clinical trial. It's important to know that the study was European-based, so patients here really didn't have access during the time frame of the study to combination regimens. And this study included a hodgepodge of papillary and non-papillary subtypes. You can see on the left-hand side the spectrum of patients that were enrolled. Papillary, chromophobe, MIT subtype renal cell carcinoma, collecting duct, many others, in fact. That's 16%. And so when we look at the data here, I want you to keep in mind this primary endpoint of an overall survival rate at 12 months. This is a very, very unusual endpoint, if I will say. It's not something that we're used to seeing in this particular clinical context. Next slide, please. So when we go to the data from this clinical trial, it's, in my mind, not spellbinding. If I were to look at a study like this, if you were to look at a study like this, any other disease type, we would say this is dead negative. It's a healthy number of patients, 309 in total. It's a well-done study, I must say. Having said that, this is not a positive trial. If you look at the median overall survival on the right-hand side, p-value is 0.29. If you look at the PFS on the left, p-value is 0.938. Clearly, no significant differentiation amongst these curves. But if you look at the primary endpoint that they so carefully selected, which is 12-month overall survival, the authors made the argument that this is a positive trial. The p-value is 0.014. I just don't think this can be interpreted as a positive study. I just don't think that we can say definitively that nivolumab and belimumab has any sort of advantage over standard of care. Let's go to the next slide here. Now, some of the key takeaways that I'll suggest is that the objective response rates are definitely higher with the TKI ICI combinations. They're in the ballpark of 40 to 49% as compared to other regimens where you see a response rate ranging between 3 and 23%. Indeed, the median progression-free survival is longer with TKI-ICI combinations. We see a range of about 10 to 18 months than with other regimens, from 4.2 to 9.2 months. But and bear in mind, as we look across these data sets, we're not replicating by any means the data that we have in clear cell kidney cancer. The response rates that we're getting here are still lower. The overall survival is still lower, but there's very promising data. And I really want to emphasize that there's a fundamental need in this case for people to get behind these randomized phase 3 studies. Folks said we couldn't do it, but you look at trials like Stellar 304, which is an excellent example of a big phase 3 clinical trial that's underway right now that might really give us a very definitive option for patients with non-clear cell kidney cancer. Next slide, please. So let's move on to papillary renal cell carcinoma. And this is a real passion of mine. It's something that I treat quite frequently in my clinics, and I've devoted a fair amount of energy to clinical trials in this particular space. You can see here a range of different clinical trials that are offered, within this particular subcategory. We have TKI-based trials that have been done, mTOR-based trials, and what we've done in this table is really broken down a lot of the studies that you've seen previously, and we've actually distilled specifically the results among patients with papillary RCC. The first trial that's highlighted there is a study that I championed called PapMet, which had response rates with cabozantinib that bested sunitinib, 23% versus 4%. The ASPEN and ESPN studies are teased out there. If you look at papillary, you see varying response rates for sunitinib ranging between 24 and 7%. When you look at other TKI-based strategies such as lenvatinib and everolimus, ironically, you see a slightly lower response rate of 15%. With beverlotinib, a study done at the NCI, 25%. So let's go through some of these studies individually. Next slide, please. We're also going to cover some of these combination trials. This is going to be, I think, a really interesting exercise because we'll see how some of the data really sort of harmonizes across different regimens. Next slide. Tyrosine kinase inhibitors. Let's go to the next slide here. This is a study that I spent a lot of time on in my academic upbringing. This is the so-called SWOG 1500 or PapMet clinical trial. This looked at cabozantinib versus sunitinib versus crizotinib and savolitinib. And I have crizotinib and savolitinib here highlighted in red because these arms dropped off. Now, this was really, really ironic to me. I was really under the impression that in the context of this clinical trial, we were definitely going to see the MET-directed therapies, crizotinib and savolitinib, really sort of drive some benefit in papillary renal cell carcinoma. After all, papillary RCC is really driven by MET alterations. Having said that, they're highlighted in red because of futility analyses that we did early on. These two study arms dropped off, and so we were left fundamentally with a combination of cabozantinib with sunitinib. Next slide, please. If you look at the data here, Pedro Barata recently updated this in the JCO. Again, he's my partner in putting this case series together. What you see here is the progression-free survival of cabozantinib versus sunitinib indeed is a bit better than what we see with sunitinib, 9 months versus 5.5 months. The overall survival, though, is really not different. So it underscores the fact that although we do have some good randomized data favoring cabozantinib, it's not an unreasonable choice in this setting. I just don't think we can say that cabozantinib is necessarily a slam dunk, right? I mean, I don't think that anyone can call this data definitive level 1 evidence. We need phase 3 trials for that, like Stellar 304. Next slide, please. This is a phase 2 study of savolitinib that we published in the JCO. Tony Chueri was the first author on this. And what you can see here is that if you really think about the way that we did the PapMet study, there's a possibility we didn't take the right approach. In the PAPMET study, we didn't actually specifically tease out those patients who had MET alterations. And if we'd done that, maybe it would have been a positive study. If you look on the right-hand side, you can see the difference that you have in MET-driven patients versus MET-independent patients. So you can see that patients who have MET-driven biology, their response rate is a lot better, 18% versus 7% overall, versus 0% in those patients with MET-independent disease. So very, very important to bear that in mind. Next slide, please. Now, what about tyrosine kinase inhibitors with immune checkpoint inhibitors? Well, I just showed you that compelling data that we have for savolitinib with good response rates, specifically in patients who are MET altered. Check this out. If you look overall, the combination of savolitinib with durvalumab, the response rate is indeed impressive. You get a 29% response rate. If you focus in on those patients who have MET-driven disease, wow, 53% response rate. So this is again, really suggesting that in papillary RCC, you can evoke responses if you take this MET-driven approach using MET inhibitors. So if we go to the next slide, there are going to be some phase 3 studies that are assessing that particular regimen. I wanted to highlight that this study is ongoing right now. This looks at the combination of cabozantinib with or without atezolizumab. This is a study that I'm running with Ben Mon. We've had struggles with accrual to this particular trial because I think people already make the assumption that TKI plus IO is better. Maybe, but we have to really show the evidence for that and do definitive studies, randomized trials that demonstrate that more definitively. So hopefully the PAPMET2 study will articulate that. Next slide, please. The PAXI-PEM study is another clinical trial in this particular therapeutic setting. I think this might have a little bit less of an academic foundation. I don't really think that the data for axitinib and pembrolizumab is particularly compelling in non-clear cell RCC, nor is the data for axitinib alone. Having said that, again, this might lend some credibility to whether or not the checkpoint inhibitor really adds benefit. Next slide, please. Now, SUMITA is the study that I was referring to earlier. We saw that compelling data for the combination of savolitinib and durvalumab with a response rate of 53%. Again, although that's very compelling, it's a single-arm study. It's a drug that at this point in time doesn't necessarily have indications within this disease type. So we do need definitive level 1 evidence, and this phase 3 trials of ways of doing this. And one of those is the so-called SUMITA study. So this is specifically going to take patients with MET-altered disease, and it's going to randomize them to sunitinib, durvalumab, or savolitinib. This is a very, very ambitious effort. It includes a number of different sites. I think it's going to be incredibly important to enroll this particular clinical trial and see whether or not we can potentially get some important data to address whether or not a MET-directed approach might potentially be viable in this patient population. Next slide. Now, what about tyrosine and kinase inhibitor and VEGF inhibitor single-arm trials? So we have trials for bevacizumab and erlotinib. It's funny. I just got a phone call this morning from one of my colleagues here in Southern California who practices at UC Irvine, and she had a patient who had been on several targeted therapy regimens, and she said, "Gosh, well, what's next?" This is this is a particular regimen that I think does bear some importance, and we oftentimes forget about it. Ram Srinivasan has presented, not published this data yet, looking at patients with metastatic papillary kidney cancer and a rarer subtype called hereditary leiomyomatosis and renal cell carcinoma. But within the sporadic cohort, what we saw was a fairly appreciable progression-free survival and response rate. PFS was 8.8 months, and the progression-free survival was actually 44%. So, I think it's worth trying in a patient who's refractory, who's out of other treatment options. Next slide, please. So what are my key takeaways for papillary RCC? In clinical trials, response rates are certainly higher with TKI ICI combinations, no doubt. And we saw the response rates range from 47% for cabozantinib nivolumab, cabozantinib atezolizumab, to 54% with lenvatinib and pembrolizumab. If we look at single agent regimens, it ranges from 0 to 35%. Now, this might lead one to the assumption that this is automatically better, but I would challenge that and say again, we want to be purists in oncology. We don't want to be misled by single arm, non randomized data. There's so many confounders in that setting. So let's do the randomized trials. Let's get behind trials like Stellar 304 or PAPMET2 and really see if we can prove that a targeted therapy, immunotherapy approach does our patients any better than targeted therapy and doesn't just add toxicity. The median overall survival varies across treatment regimens from 14 to 22 months, and outcomes were better for MET-driven versus MET-independent tumors if you're going to use a potent and specific MET inhibitor like savolitinib. Next slide, please. So what have you learned after this? Which phase 2 combination study for non-clear cell renal cell carcinoma demonstrated the highest objective response rate? Cabo-Nivo, Len-Pembro, Nivo-Ipi, or Cabo-Nivo-Ipi? Let's take a peek at that and see what you guys got. I'll give you guys a moment to answer here. Just remember, we've highlighted actually the data for all of these regimens. Perfect. We've got 100% here. Lenvatinib and pembrolizumab. That's absolutely right in the Keynote B61 clinical trial. Let's jump to the next slide here. Let's go through a case example. I think this will be a nice way to sort of put everything into context from what we've learned today. Next slide, please. A previously healthy male in his late 60s presents to his primary care physician with persistent, unexplained flank pain and hematuria. His initial workup includes a CT of the abdomen and pelvis showing an 8-centimeter mass with invasion into the renal vein. There's no distant metastases. He has no medical history. He has no family history of cancer. He's a former smoker quitting 15 years ago. He uses alcohol only occasionally. Next slide, please. So, the differential diagnosis here has to include renal cell carcinoma indeed, right? But it does also include other possibilities, oncocytoma, angiomyolipoma. You do a percutaneous core biopsy of the renal mass, and it shows non-clear cell kidney cancer, specifically papillary RCC, and your specific molecular testing is pending. Next slide, please. So based on the CT scan findings, this patient has pathologic T3A N0M0 disease with invasion into the vein. This case is presented at tumor board with urologists and medical oncologists. The patient has 3 treatment options that are considered. Surgical resection, indeed, I think that should probably be the primary step. Active surveillance. There is papillary RCC that's indolent. I worry about this a little bit because this is an 8-centimeter tumor invading into the vein. I think the propensity for metastasis is quite high. And then there's ablation. I will say that ablation is probably not going to be a premier option for this patient due to the tumor size, the location. I would also say that ablations get tricky when you get into veins. And there's a nice case series from Jeff Kadedu at UT Southwestern that really suggests that maybe 3 or 4 centimeters is the size that we should be targeting for ablative procedures. Next slide, please. So this patient undergoes a successful robotic-assisted partial nephrectomy. This shows grade 3 papillary renal cell carcinoma with sarcomatoid features and microvascular invasion into the renal vein. Margins are negative, and you do molecular testing that shows MET amplification. The tumor board convenes to discuss adjuvant therapy given the high-risk features, and the patient's certainly in high risk for recurrence. So what treatment approaches would you consider in this setting? If anybody wants to volunteer, that's fine. If not, I might suggest here, gosh, for papillary kidney cancer, this is a very interesting case because I would almost never recommend using adjuvant therapy. But what really sort of changes my perspective here is this presence of sarcomatoid features. Whenever I see sarcomatoid features, I think about the adjuvant pembrolizumab data that we have. And indeed, it looks as though patients with sarcomatoid features seem to fare far better with pembrolizumab. So I'm going to be giving this patient pembrolizumab most likely. They didn't have any medical history suggesting comorbidities that would complicate things. So I think that would be the preferred option. Let's go to the next slide. So, again, there's several key trials that inform our decision around adjuvant therapy. PapMet was in the metastatic setting. Savolitinib showed promise, but also in metastatic disease. TKI, ICI combinations have shown promise. But again, all the data that we've gone over is really for metastatic disease. Next slide, please. So, this is a really important shared decision-making procedure. I would suggest that, in this particular setting, this patient expresses a desire to pursue the most aggressive approach, minimize risk. The patient had MET amplification, but it was suggested the patient have simply active surveillance in the end, which they pursue. If you can back up 2 slides, if you don't mind. Yeah, this is interesting because I would say that, in a scenario like this, I would probably really try to push the patient towards adjuvant pembrolizumab. And if they were looking for that aggressive approach, I want to emphasize that because of the sarcomatoid features, not because of the papillary features, that would have been my choice. So let's go 2 slides ahead. Sorry about that. Okay, so this patient gets monitored every 6 months with CT scan or MRI to detect disease growth or spread. I tend to be maybe a little bit more aggressive about imaging. I tend to do imaging every 3 months for the first 2 to 3 years, and then I slow down thereafter. But it's not unreasonable. Let's go to the next slide here. So now we're going to go to the key takeaways for this lesson. Which of the key takeaways from this session is particularly relevant for your clinical practice? In clinical trials involving multiple RCC subtypes, objective response rates with TKI ICIs are higher than with other regimens. Is the median PFS with these combos? Is the median overall survival? Or is it the data from clinical trials specifically in the context of papillary RCC? Which one of these do you think is probably the best key takeaway? I'll give you a moment to answer that. And then we'll jump to the next slide here. And let's go to an action plan. So based on the key takeaways and the case discussions that we shared today, which one of the following changes applies to you? Will you consider ICI TKI-based combinations regardless of subtype? Will you use it preferentially maybe in papillary RCC? Will you remain up to date on the latest results from clinical trials? Will you take into account MET expression? Will you share the results of the latest clinical trials with your multidisciplinary care team or other? These are all great options, I suppose, but we're very interested in kind of better understanding which amongst these is most critical to you. Let's see what other people chose here in just a second. This is a longer question, so I'll give you a little bit more time. If I might add to other, just disseminating the available clinical trials in this setting, because when we see these patients, I think it's key to bear in mind the fact that clinical trials should really still be option number one in this context. So it looks like all of these options really sort of struck a chord with our participants today. And by the way, I'm happy to answer questions in the chat if you don't feel comfortable shouting them out. Any questions before we wrap up today? If not, I really wanted to thank you, the France Foundation, the Kidney Cancer Association for this really rare opportunity to spend so much time really distilling and discussing non-clear cell kidney cancer. Oh, thank you for the nice message, Kenna. And if you want to claim credit for this event, Ashley's put a little link in the chat there. And with that, I'll turn it back over to you, Ashley. Oh, sorry. We've got a question from David Tran, who says, what would your recommendations for translocation RCC be after len-pembro? It's a very good question. So if I saw a patient who received len-pembro in the frontline setting and progressed, I would suggest single agent cabozantinib there. There's no obvious strategy in this particular setting. Obviously, the Stellar 304 clinical trial that we highlighted does accept these patients in the frontline setting, not in the refractory setting. So that would probably be my preferred approach. But I do think if that option has been exhausted, single agent cabo would probably be my choice. Thank you, David. And then we have a rapid recap that's been posted as well of session 2. Thank you, Ashley, for that. Ashley, anything else before we conclude today?
Sorry. Let's see. There we go. No, that's it. I put the link for the evaluation in the chat. I will also send out an email with these same links just to make sure that you have them after today's session. And then I will send an email as we get closer to session 3. Please register for that and or session 4, whatever fits into your schedule. There's 2 options for each of those sessions. So Dr. Powell presents one and Dr. Barada presents another, just to give some different date and time options. So that's all I have for today. Thank you, Dr. Powell, for a great presentation, and I hope that you all have a great Friday and a nice weekend.
Thanks, guys. Bye-bye.
Thank you. Bye.